Entering this meeting on mute, and the request for the good of the meeting and the clarity of the responses is that we stay on mute throughout this meeting unless you're one of the speakers. So we appreciate that. So a quick introduction, and I'm going to introduce some folks with really long careers and long tenures in Palm Beach County in a sentence or two, so that we can devote most of our time this evening to the content. First is Dr. Larry Bush, an infectious disease specialist who's been in Palm Beach County more than 30 years. Dr. Bush has several academic appointments. He's an educator, he's a writer, and he's a terrific speaker. Second is Dr. Alina Alonso, who's the Palm Beach County Director for the Florida Department of Health, who also holds several academic appointments and oversees numerous public health programs in Palm Beach County. Third is Dr. Paco Arrascue, a nephrologist who's been engaged in organized medicine and a leader in several of our local hospitals, and who's been a quality advocate for patients in our community at every turn. And lastly is Darcy Davis, the CEO of the Healthcare District of Palm Beach County, a role that she's held since 2016. She's been with the organization since 2011. She oversees a very diverse and complex public health system for us. And so we're really thrilled to have these folks offering their thoughts and opinions in this most unusual time. So given that introduction of our speakers and the format, and again, reminding the folks that are just coming in to please stay on mute if you can through this, we'll begin with the first question that I think everybody would like an answer to. And that question is, what tests are currently available for COVID-19? And give us a sense of how accurate those tests are with the latest information. And we'll go first to Dr. Bush.
Thank you, and good evening, everybody. And Jim, thanks for putting this together. I know the questions you put together are quite important, and hopefully we'll provide some answers that are helpful. So my first question is, what tests are currently available and how accurate are they? So as you know, in infectious diseases, we'd love to diagnose infections by isolating the organism. In this case, that's not something that we can do clinically. That's in a research lab. We can't grow the organism clinically. When you think of the idea of testing, there's two reasons for testing anybody for anything. One is something that you would say you're looking for their knowledge. That would be like an aptitude test or a scholastic test when somebody's entering college or applying for college. The second is the one that we use in medicine, and in medicine we use tests either to make a diagnosis, to assess the severity of the diagnosis, or to see how well our treatment is working, or to look for complications. Now, we're not shy about doing testing in this country. We have a country of 300 million people. We do 13 billion lab tests every year. So there's nothing shy about ordering tests in the United States of America. So when we're talking about testing for coronavirus, which we're calling COVID-19, which is SARS type 2, what we're really trying to see is, do you have the infection currently? Have you had the infection, or are you immune? And some of these come with different tests. So what we're hearing is that we're doing PCR tests. That's basically you're swabbing either their nares, their nose, their nasopharyngeal area, their throat, their lower respiratory tract, and now there's also a saliva test that's commercially available. And what we're asking the test to do is to identify RNA, to identify the gene of this particular virus. The tests that we're using, either the commercial ones or the ones in the hospital, are FDA, EUA approved, meaning they've been proven to be accurate. When you do a test, you look for sensitivity. In other words, you don't want to have false negatives. A sensitive test can detect it. And you're looking for specificity. In other words, you don't want to have false positives. However, when you have a disease with low prevalence, which this is, a test doesn't necessarily mean that they truly have it. Also, the caveat with having a PCR test is, when does it become positive, when they're symptomatic or before? And how long does it stay positive? And when it does stay positive, does that still mean that there's viable virus? And the answer to that is no. The answer is it becomes positive quite quickly. It then generally within 5 days, everybody who's been infected has a positive test if you look for it. And how long they keep it's really irrelevant, because just because you can have a delayed positive PCR isolate doesn't mean that you're still infectious. So then we go to serology tests, which we're all used to ordering antibodies, and hopefully the body has built immunity to the pathogen, in this case, the virus. that you can detect either acute IgM or antibodies or delayed antibodies we call IgG. In the case of COVID, we have two types. We have the point of care test, which we have to remember, a lot of them are not FDA, EUA accredited or vetted. And we have the ones that are done by commercial labs. And when you compare them to the PCR, if they've been vetted, they're pretty accurate. The problem is having antibodies doesn't mean that you're actively infected. It doesn't mean when you were infected, and it certainly doesn't tell if you're immune or can no longer get this again, because we don't even know if the antibodies are neutralizing antibodies, how long they last. And as we know, a lot of viruses produce antibodies that don't necessarily protect you, HIV be the classic. So that's a relatively short answer to a long question.
Thanks, Larry. Dr. Arrascue, comments on available testing and accuracy? Let's see if we have Dr. Arrascue. All right, Paco, we will circle back to you for that answer in just a minute as we get your audio up and running. I'll move on to the second question, which is, who should get tested and under what circumstances should asymptomatic folks get tested? And we'll go to Dr. Alonso first. Dr. Alonso?
Sure. Well, the high priority obviously is going to be hospitalized patients with symptoms, right? And then we have the healthcare facility workers, anybody that's in a congregate living setting, first responders that have symptoms, residents in long-term care facilities or any other congregate kind of living. And we're also including the prisons, shelters, any area like that with people with symptoms. Then we have the other priority of persons with symptoms who have been having the symptoms, including the fever and the cough and the shortness of breath that we started with, and then we added the sore throat, and then a little bit after we went ahead and added chills, muscle pains, loss of taste or smell that became very prominent in many people, and then vomiting and diarrhea. So we now have a few more symptoms to consider, but they're all very vague symptoms. So people without symptoms might be prioritized either by the health department or by clinicians for other reasons, including monitoring or surveillance, or when you have other symptoms that you want to eliminate. The problem right now is that with the people knowing that there are asymptomatic individuals, the problem comes, well, who asymptomatic should we prioritize, or should we even test anybody who's asymptomatic? So we have to use some judgment. The recommendation from the CDC is that the only people asymptomatic that be tested are those who have been in contact with, which we either say, hey, you've been, we call a person when we're doing our contact tracing, we say you've been in contact with an individual who was COVID positive, you need to go get tested. Or if it's someone who believes that they have been in contact with someone who is COVID positive. So those individuals may not have symptoms at all. The problem with testing someone who is asymptomatic is that if they have not had enough days, that they don't have enough actual virus in their body, they have a test done, they're going to have it false negative. So we want to make sure that they have at least 5 days before they have that issue of coming to ask to be tested because they believe they have been in contact with someone who's who is COVID positive. The other group that is being tested is mandatory testing when we're going now to long-term facilities, correction facilities, and we're testing both staff and patients in those facilities. And there are other health workers who are being tested routinely as part of that test, as part of screening for healthcare workers. Something weird just happened.
Thank you, Dr. Alonso. We'll go to Ms. Davis and ask how you're handling testing at the healthcare district.
Yeah, so we started the process of testing, mid-March, and we were asking a lot of questions and in terms of symptoms and trying to screen out those that, we felt like would be most likely to be positive. And over time, what we started seeing is that a lot of people were presenting with very strange symptoms, not the typical, fever. Everybody was zapping and looking for the fever. And a number of people were testing positive that had never had fevers. In fact, one of our residents tested positive and her only symptom was loss of smell and loss of nose hairs. So at a point, mid-March, early April, we stopped asking a lot of those screening questions in order to allow someone to get tested, and really opened up the criteria and, started looking for self-declaration of their circumstances. So, people do call us. We test everyone of all ages. We have pediatricians that work with us, so we're able to test, children. We have 6 different locations where we're doing the testing, but we aren't asking specifically, what symptoms do you have? We're asking, did you have symptoms? Have you been exposed in order to test somebody? And I think, we're seeing a lot of not unusual, but not your typical symptoms. For example, no fever, no coughing, just 1 or 2 maybe minor of the CDC listed symptoms, and the symptoms are so very broad that we just really opened up that criteria.
Thank you for that. The next question is, so we have a patient who tests positive. What do we tell them, and how do they move forward with their lives? And I think we have Dr. Arrascue back. Dr. Arrascue, can you hear me?
Yes, I can hear you. I'm sorry. Somehow my computer went blank and I couldn't get back into the conference.
Well, we're glad you're back. And again, we're now talking about positive tests and patients that test positive. And so what is it that you tell them after they have a positive test, assuming they're not hospitalized? How do they conduct themselves? How do they move forward with their family and their friends and their lives and business?
One of the main points to be made, first of all, is that this is an evolving field, and the antibody testing is controversial nowadays. There's a lot of information saying that you may have a lot of false positive tests, and that depends on the quality of the test, but also depends on where the test is done. If you have a place where the prevalence of the disease is very low, then the test may be false positive or false negative, and the test is not very powerful to predict. But assuming that you have a positive antibody test and you have no symptoms, you can go to the time strategy or the test strategy, as the CDC calls it, also the AMA. The test strategy that you have no symptoms, so you can wait maybe for 10 days, and if you continue having no symptoms, you can go back to your normal life and be in touch with other people. Hello, can you hear me?
We can.
Okay, very good. If you have a positive test and you want to know if you have the virus in your upper airway, you can go to culture, and some other recommendation is to do 2 negative cultures before you go back in the community, so to speak. But most people who have a positive antibody test and they have no symptoms, they will just may presume that they have been exposed to the virus in the past and they are now asymptomatic. So those are the possibilities of things that you can discuss with the patient when that happens.
Thanks, Dr. Arrascue. Dr. Bush, can we ask you to chime in about positive testing and advice to patients?
So right now, the recommendation is that if you tested positive and you're symptomatic and it's been 10 days since your disease onset, 3 days since all resolution, there's really not a reason to retest, because studies show that even if you have a positive PCR, it doesn't mean you're contagious, and nobody can really say when that will end. On the other hand, if you test them twice, and with the retest method that Paco just said, we're talking about PCR, not antibodies, and obviously we don't have cultures. If they still remain positive, the problem is there are people who remain positive for weeks on end. It doesn't mean that you're doing anything for them, or you're doing anything for infection control. The only usefulness right now for serologies is for epidemiologic studies for prevalence. And remember, as a disease cures itself, like most viruses do, the prevalence will be eclipsed by the incidence, because prevalence can only be measured long-term as if you have a disease that doesn't go away, such as HIV. So my feeling is that if you're clinically improved, it's 10 days since you tested, since your onset of disease, and it's 3 days since you've recovered without symptoms. I don't see a reason for any further testing whatsoever.
Thank you very much. So next question, and Dr. Alonso, I'm headed to you on this one, but you actually mentioned this in one of your early answers. So we're reading and hearing a lot about different strategies for contact tracing. Can you tell us what's happening in Palm Beach County if somebody tests positive, and do we trace contacts, and what do we do with that information?
Absolutely. Contact tracing is really the basic building block in epidemiology. And it's very, very important. We actually have trained people in doing contact tracing. We don't just use anybody off the street. We've got tons of volunteers that want to do this kind of stuff. But at this point, we have, right now in Palm Beach County, we have 28 contact tracing individuals plus additional staff that we have in the epidemiology department, for a total of 44 people who are doing contact tracing in Palm Beach County. We're up to date with our testing, and today's fury of reporters were all about the 100 and some new contact tracers that Miami asked for, and why don't we in Palm Beach County have 150 contact tracers? So you know, Miami definitely has a bigger population. They have a much different load in Miami than Palm Beach County, number one. And number two, we're up to date with our contact tracing. And if we need more people, the state will send us qualified, trained contact tracers to come to Palm Beach County. Now, what happens in that contact tracing? The first thing we do is contact the positive person who has been tested. We do an extensive interview. It's about 4 pages, questions, and in those questions, we ask who were their contacts that they were involved with, that they were next to, that they were working with, that they were living with, that they might have shared space, and it's very detailed. And then we interview each one of those people, asking them to go get tested, asking them, again, many questions. And sometimes we then find a third contact to those people that then we have to continue that questioning. There are certain skills that need to be done for case investigators. They have to be active listeners. They have to be able to use open-ended questions. They had to be motivational in their interview so that they can elicit, and they have to build trust with that person. It's very hard to build trust when you're just talking to a person for the first time in your life. They have to be skilled in risk communication, problem solving, and even emotional intelligence skills. They have to have cultural sensitivity. We obviously here in South Florida have a very different culture than, say, Tallahassee. And so we want people that are sensitive to our area here and that can obviously have to speak sometimes multiple languages. We also have a language line that we utilize when we're talking with people, or if they're hearing impaired or deaf or have any other kind of problems, we have to be able to make contact with those people also. So we just don't pick up a person off the street to do contact tracing. Now, the other group of people that we are trying to be innovative and reach out into the community, we're going to be using community health workers, which you know that the Palm Beach County Medical Society has a program that actually gives these people a certificate. And that's part of what they train these folks with motivational interviewing skills and risk communication skills. So we're going to try to use people who are not employed now to get them trained through Career Source and get those people out into the streets, working with some of the outreaches that we're doing, working with some of the pop-ups that we're going to go into high areas of high numbers of people who we think need to be still tested. Some of the areas where we have, looks like we have folks who have not been tested yet, and go into those areas and then try to do that community outreach, that, you know, epidemiology, boots on the ground, going from person to person, door to door kind of thing, where we actually get into the community and are able to speak to many of these people who have no idea what COVID is. As a matter of fact, we had an example of a woman that came pregnant, and she had no idea that she had been tested for COVID. She thought it was something good for her pregnancy. She thought being positive was something good. So there's all kinds of levels of understanding out there, and it's very important that we do more education in the community so we can try to put a halt to the epidemic and to the spread of the COVID here in Palm Beach County. The other piece that has hindered our contact tracing is that you want to get this as soon as possible, right? Because one person spreads it to 3 more people. So if I get a test result that has taken 11 days, I have lost so much time in terms of getting to those people to stop them from spreading it to other people. So we had a conversation with the Surgeon General, and we explained that this whole issue of having these tests come back quickly is very important for that contact tracing to be effective.
Thank you. Really thorough answer. I'd also like to ask Ms. Davis what contact tracing looks like through the lens of the healthcare district.
Well, my answer is a lot shorter than that, because we do rely on the health department to do all the contact tracing for our patients. I think the only thing I could perhaps add is that, you know, as part of our reopening strategy, you know, we have 1,300 employees at the healthcare district, and part of our reopening strategy has been daily screening of all of our employees and then monthly testing. And so in order to do all of that, we developed an employee health department led by, we happen to have a physician who was trained in epidemiology who leads our employee health effort. And, you know, as healthcare workers, it's important that we get ahead of, you know, any exposures of our employees to our patients or to other employees in the organization. So that employee health team is doing smaller scale, you know, contact tracing with our own employees when we've identified that there may have been a potential exposure. So we're actually taking that on ourselves, even though those results, because they are still patients and it gets reported to the database, even though that would go up to the health department, you know, for follow-up, we're really trying to get ahead of that. That's probably all I can add, at least on the contact tracing end.
I can add that she's very well trained because she used to work for us in epidemiology.
I've got 2 of yours, so I only mentioned 1, but I've got 2 of them you trained, so.
There you go.
Jim, can I jump in and ask Dr. Alonso one caveat with that?
Absolutely.
So my question is, Dr. Alonso, so when you do contact these people who've been exposed, and the definition of exposure is within 6 feet for 15 minutes, which you know is very hard to discern in large groups. Exactly. It's easy in household, difficult in the workplace or in public. But when you have a contact and you send them for a test, what do you do with the symptomatic versus the asymptomatic, the positive versus the negative? Because my understanding is they're all treated the same. They're treated for quarantine for 14 days, whether they're positive, negative, symptomatic, or asymptomatic. So what is the difference of why test if we're going to treat the 4 groups the same?
Well, you when they're asymptomatic, if they've been a contact and we tell them to stay home and check their temperatures, they're reporting back to us if they become symptomatic. And it's a little bit different in terms of what we're telling them to do. They can still go out, you know, we're not keeping them homebound the same way that we're keeping somebody that, well, I'm going to say that we're trying to keep people homebound if they're positive, they've been tested positive, versus the ones that just may have been in contact with someone who may or may not. So there's a little bit of difference in that, but other than that, we want to know if they do become symptomatic, and we want to test them, I guess, more for the statistical reasons of knowing that we have the test than not. I mean, we said that early in the beginning of the pandemic, right? That the real reason for testing is to have knowledge of the test itself. If the person's going to recover in 14 days, it really doesn't matter whether they get tested or not for the individual or for how we treat them, because there is no medicine, there's no treatment modality other than for them to stay away from people. So you're right in that sense that testing them doesn't help in terms of doing anything different for them. Is that the point you're trying to make?
Yep. Thank you for the clarification and the addition. So Dr. Bush, I want to circle back to something that you had said earlier. You gave us an example of when not to repeat testing. Can you just tell us when you do repeat testing, under what circumstances?
Yes, the only time I repeat testing is when somebody has exposure and symptoms and their first test is negative, or they have classic or semi-classic symptomatology and their first test is negative, because as was, I think, said before, a lot of the sensitivity of the test isn't so much on the platform of the test or the science of the test, but the sample collected. And it's a little bit more difficult to collect a nasopharyngeal sample, and the ability to isolate the PCR, the RNA, the gene, looking for different genes that the test had, basically, it is a little bit higher sensitivity when you look at nasal versus nasopharyngeal versus deeper lower respiratory tract. So I repeat testing in somebody who I think clinically still may have the disease but tested negative. I'll try to do a different type of sample and make sure it's a quality sample. That's the only time I repeat testing.
And I'll open it up. Anybody else like to add to that?
We're also doing.
This is Paco. Can I say something?
Sure, Paco, go ahead.
Sure. No, well, just echoing what Larry just said, I have been part of the team taking care of patients who were clinically, COVID infections, because they had a very strong epidemiological background, and they were sick, and the cultures were negative, and the third time the culture was positive. So that's an important thing. The other thing that I would like Larry to comment perhaps is the point that when the patient is getting better, what nursing homes and skilled nursing facilities are saying, you have to have 2 COVID tests 24 hours apart negative before you can be transferred. Knowing that some of that could be a false negative, but still that's what is required. So there's other people who think a little bit different than Larry.
Yeah, and the reason for that is, Paco, because 85% of the deaths, not only in the United States, but in the world, were in that population, people who were over 65 and infirm, and therefore they're the greatest risk. So the problem is that a negative test doesn't mean that it was collected correctly or can't turn positive, and a positive test doesn't mean that they're contagious or have viable virus. But you're looking at your most vulnerable population, and that's why that's slightly different in them. Not for any scientific reason, it's strictly emotional.
But, it's more than emotional. It's the probability of being right goes up if you taste it twice, because the first could be a false negative or a false positive.
Right, but the problem is that after you've been diagnosed as active disease with a positive PCR and you're asymptomatic for 3 days and it's been 10 days, having a positive test does not mean you have any viable virus. And therefore, we're never going to be able to transfer anybody to a nursing home. I'm not disagreeing with that. I'm saying that's the issue. You're going to put them in a situation where we don't have an exact test and you're taking a very vulnerable group. But that's the reason why the nursing home.
So let's shift gears for a second and talk a little bit about the finances of COVID-19. And I know a lot of people are concerned about how to pay for testing. Can I ask the group, start with Ms. Davis, about who's paying for tests when you're getting folks tested in your system?
Yeah, so in all of our sites, there's no charge for the patient. So We have the 6 locations, 2 of those are the drive-throughs. The FIT team does the highest volume, but none of those are we charging. And that's because the kits that we're using are provided by the state. So the state has entered into a contract with a lab, and they provide all of the kits, and then they also provide all of the testing with GenetWorks is the name of the lab, and they've provided all of the support services for us. So we're the providers on the ground, but no charge. That there is a downside, I would say, to that, and that is because of the high volume. The lab is taking about 7 days to turn around a test when we use those kits. When we use other kits on, Quest, for example, or even LabCorp in other circumstances, those results come in a lot faster, 24 hours to 48 hours, but still no charge.
And Dr. Arrascue, can I ask your experience on paying for tests out in the community?
Sure. I mean, it's important to remember that the Family First Coronavirus Response Act that Congress passed requires all private insurance to pay for COVID-19 testing. And the correct Act that follow the prior law expands that concept that the insurance companies and Medicare should pay for the test. But there's some particular things that people should remember. For instance, if you go to see a doctor for a COVID-19 possibility, and the doctor feels that the COVID-19 testing is not available, so they need to do just the influenza and other viruses tested, but they don't do a COVID-19 test, then that visit may not be covered because COVID-19 was not particularly specifically done. So that is something that people have to remember. The doctor has to order the test, either going to the health department or going to a private lab in order to get paid. As you know, you can do a test on your own. You can go to Quest for $119. You can get a test. I myself did it with a healthcare district. It was inexpensive, nothing. And my antibody was negative. The culture is pending. But in general, right now, as I said, insurance companies are mandated to pay for the testing for people who have insurance and for Medicare patients.
Thank you for that. So another question, is about how we educate everybody in the community about testing. There's about 50 folks on the call tonight getting information. I know when I wake up and I turn on the news, it's either the weather or where you can get tested. So I think, the media is doing a great job of this, but just ask the participants about community education. Start with Ms. Davis on testing options.
Yeah, so I think there's a lot of different ways because you're trying to appeal to a lot of different cultures in our very large county. And I think, it's going to take trusted members of the community to really help spread that message that this is, as Dr. Alonso used the example earlier of somebody who really hasn't got a clear understanding of what's going on. And I think there's just certain neighborhoods, certain communities, there's an underlying mistrust of government, of what's going on. I can tell you that I know even in Belglade, for example, we have the National Guard who is helping with logistics, and there are a number of people who will never show up at our site because they see the National Guard, and that's very intimidating. And they're also at the ballpark, so we may never see people. Some of the testing strategies have changed, and that's going out into the neighborhoods and the communities. We've started pop-up testing in the neighborhood, but I think there are obviously language barriers that we have to overcome, but I think deeper than that is a trust issue. And so people who have the relationship and the trust with their patients or clients in some community agencies, they're going to probably be the ones that the individuals are going to turn to for, guidance and support. So I think arming everybody with as much information as possible is the best way to get the word out.
Thanks. And I'll ask Dr. Alonso, I know education of our community is first and foremost on your priority list. How are you getting the word out on testing?
Well, I think we have to rely on the concepts that we used to have of public service announcements with the new technology that we have with social media, and I don't even know all the names of all this stuff, okay? But we have to put this in the hands of the people that know how to handle the media. I certainly am working with my public health information. We're working with the county. We have short videos. That's the new thing, short little tiny videos that people like to watch, and just flood the airways or the internet and everything else with information about COVID, information about how to stay safe, information of how to protect your community, and information about the virus itself, what it does, what it doesn't do. I don't think there should be fear. I think there should be education. This is not a virus that's going to kill everybody. We see it over and over again that the 90% of the people are over the age of 55. And so the average person is not going to die with this. And as we test more and more people, we see that, that we'll get to the point where we see that this is not a lethal killer that's going around killing people. And I think that fear has to go away. But at the same time, we can't be ignorant of the fact that we are spreading this virus by not maintaining social distance, by not stopping people from spreading it to those who are vulnerable or those who do have immunocompromised systems. So therefore we have to be careful, and we should be, nobody wants to bring this home to their grandmother or to their aunt or to anybody who is sick at home or has cancer or is under treatment. So we need to get more information out there so that everybody understands this without the fear, without the politics, definitely. This is not red or blue or purple. This has to be just pure education and knowledge about a virus that is like the flu, but that has affected a lot more people this time around than when we had the pandemic back in 2009. It was handled and appeared much differently.
So it's a scary time for a lot of folks in the community. I think it's been particularly difficult for parents and worrying about their children. The path for young folks has been interesting. First, probably not that significantly affected, and now hearing about some interesting, unusual things in small numbers in certain places. But the question on everybody's mind is, when do we get to go back to school? And so if I could, ask the group to talk a little bit about testing as it relates to going back to public school or colleges or universities, or maybe even broader, just back to the community, but with just a particular focus on school. Start with you, Dr. Alonso, if you don't mind.
I don't think it's so much about testing, but about the basic principles of the hygiene and the cleanliness that needs to occur when we go back to either work or schools or any place where there's going to be a lot of people gathering. So the schools have been asked to very specifically look at, are they going to be protecting the students in a way that they will be able to be spread out far enough where they're not going to be able to spread the virus? Are they going to be able to screen students and employees who have symptoms, or how quick are they going to catch these symptoms before they have exposure to more people? And so there's one sheet on the CDC guide website that, I don't know if you can see it here or how to get it to you, but it's specifically talking about schools. And if you want to go there, so it's kind of if any of these things apply, then you have to stop and you're not ready to open. If you can say yes to them, then you can proceed to the next one and to the next one until you actually can open and monitor. The school district here is doing a really good job of looking at all the things that they're going to have to do to attempt to be able to go back to school, hopefully with the new opening of the new school year. But they're not sure yet if they're going to be able to do that or not. So, they're going to just have to be able to promote healthy hygiene, practice the hand washing, having people maybe wear masks or not, identifying the surfaces and cleaning as much as they can. And, you know, for example, I don't go around cleaning everything. What I do is clean my hands. The virus is not going to jump into you, right? So if you practice these things and you have that ongoing mindset that I think we're going to have into the future until the vaccine is actually developed, that's just going to have to be the new way that we handle ourselves in society, since this is worldwide. Please go on the CDC website and you can see more of all these questions that are being asked. But I don't think it's so much testing as it is practicing hygiene, practicing distancing, and being able to quickly test folks who are positive, and be able to monitor your symptoms and being able to stay home if you're sick so you don't spread it to other people.
So we'll put that sheet that you just showed on the Palm Beach County Medical Society COVID-19 resource page for anybody that wants to follow it, and if they can't find it on the CDC site. And I'll just ask also, Ms. Davis, if there's any comments on getting back to the community.
I mean, I think in terms of reopening, there's three principles for all of this, and Dr. Alonso said it well. It's, you know, diffusing density, it's hygiene, and then it's, you know, this combination of screening and testing. So monitoring symptoms, and that's, to me, the thing that we've done differently. And I would say that, you know, it may or may not work depending upon the size of the organization, but is the daily screening. Every single day, every employee in our organization gets a text, and that text has a list of questions, and it's those symptoms. So everybody is self-declaring, you know, their symptoms. Do you have a fever? Do you have a cough? Do you have shortness of breath? Do you know, it's those standard questions, and every single day, there is someone that is taking a look at that, you know, the answers to that. And if they answer yes to any of those questions, there's follow-up by a trained health professional who gets to the bottom of it. Well, you know, one of the questions is, you know, do you have a sore throat? Well, if the answer is yes, our person's going to give them a call and get to the bottom of it. And maybe they were just screaming at the TV last night, and that's why they have a sore throat. So come on back to work. But I think that is what, you know, that level of screening, we put a lot of effort in on the front end of that, and the platform, and, you know, making sure that people are following through and answering a very quick text. But I think that can be done, and that can be rolled out in a lot of other forums. And so in the school environment, you know, you're looking at your faculty perhaps and saying, answer these questions very quickly. And if you have, you know, yes to some of these, stay home till you hear from us and let us find out whether it's appropriate for you to come back, because that's going to prevent that sick individual from coming in. You know, usually the answer I get to that when I talk about this, people say, well, what if they lie? Well, I mean, yeah, that's a possibility. You know, they could lie and tell you they didn't have symptoms and they could come in anyway, but they, you know, you could also get sick at the grocery store too. So, you know, we do the best we can for the most amount of people that we can under these circumstances. And I think though that health professional and analyzing that screening will also help determine whether a test is needed. So instead of just testing the whole world and hoping you get a hit, or hoping you don't get a hit, you know, you've got a little professional judgment going on behind the scenes to help figure out, is a test necessary? And then, you know, what do I do while we're waiting for the results of that test?
Jim, if I can make one comment there, I appreciate both of those comments, is keep one thing in mind, is that 15 to 20-fold greater asymptomatic cases than symptomatic. And we know that asymptomatic people carry the virus and can't spread it. That's why the contact tracing. And we also know that they probably have less spread because they're not coughing, they're not as ill, so they have less viral load. Asymptomatic people probably have less virus to begin with, have less symptoms, less spread. The point being is that if we're just screening symptoms, we're missing 15 to 20-fold more people who could potentially spread it. I had the privilege of looking at the state's Department of Health plan, which mirrors the CDC. It was sent to me by the FMA, myself and an infectious disease doctor at the University of Florida. And I looked at it and I thought it was great. I mean, and the only comment I had for the Surgeon General was, with one caveat, you have to write the advisor, this is not a guarantee that your child or you can't get ill at school. As long as everybody knows that, because the question I ask people when they say, is it safe for me to go? My answer to them is, how do you define safe? How do you define risk? How risk adverse are you? And I can never tell you there's no risk. I can tell you that the amount of cases are dropping, that the percent of positives are dropping as we do more testing, that the hospitalizations are dropping. That's all good news, but I can't tell you there's no risk.
So Larry, I want to follow up with you on another thought, which is we're talking about getting back to normal. One of the ways we're going to get back to normal is when a successful vaccine is rolled out. Let's not worry about timing, whether that's 6 months or 18 months. We're here talking about testing tonight. And can you give us some insight if a vaccine is deployed? Is there a testing strategy that's associated with that?
So that's a good question. So other than testing, the other big buzzword obviously is vaccine, and everybody feels, when a vaccine's available. Keep a few things in mind. The 3 most impactful diseases in the world, which are malaria, tuberculosis, and HIV, there's no vaccine. The #1 cause of infectious disease in the world is TB. We have a lousy vaccine. The most common infection in the world, malaria, no vaccine. The most devastating epidemiologic event that's ever happened in humanity, HIV, we have no vaccine. So it's easy to say when we have a vaccine. Keep in mind, we never had a vaccine for SARS. We never had a vaccine for MERS. They both went away. There was never a resurgence, and we still don't have vaccines for those. Secondly, a vaccine doesn't guarantee immunity, and it only is good for herd immunity. The reason why we've had outbreaks of measles and hepatitis A is because in the pockets of the country where people philosophically don't get vaccinated for lots of reasons, or their children don't get vaccinated, you don't have herd immunity. So you have to be able to develop a vaccine that produces protective immunity. That's quite hard to do. You have to make sure that a large enough percent of the population gets vaccinated and they don't need boosters, because if you don't have herd immunity, it won't work. And you have to be able to say that not everybody's going to get vaccinated for various reasons. So yes, the major thing that's ever affected medical care in the world or infection control in the world is sanitation, clean water, and vaccines. But for the majority of devastating infections in the world, we've never had a vaccine. We maybe never will. Hopefully we'll have a vaccine. I think the political nature of this is such that the FDA will approve any vaccine quickly without really knowing how protective it is over time. And that could give a very false sense of security, because there's no way of knowing of any test other than the fact that you can produce antibodies, how protective in any one individual that vaccine will be.
Dr. Arrascue, thoughts on vaccine and testing
Sure.
as it rolls out?
Sure. Before I go there, let's just make a point about the prior question that you had about how should we prepare, businesses to open and colleges and universities and stuff like that. Clearly, one of the things that we have to remember is that the measures that are recommended right now, from distancing, masking, hand washing, checking for symptoms, that bundle of actions work. Dr. Atul Gawande wrote an article in the New Yorker just last week when he made the point that in the Harvard hospitals, who have over 75,000 workers, they have a very low incidence of infections in the people who go to work, because they established a culture of being very, very careful with that. In big elevators, we used to have 20 people, they only could have 4 people. If you saw somebody who had a mask was under the nose, they said, please fix your mask. Don't talk to me too close. They did meetings by video, even that the patient was next door. All those maneuvers are still going to work, because that's the best that we have. Is cheap and it works. Certainly, we have to also create a culture to tell people that we have to take care of each other. That is something that this virus gives us that opportunity, because when I use my mask, I'm primarily protecting you from getting my secretions, and vice versa. And we may be infecting somebody who's immunosuppressed or who has a chronic disease, or the immune system is not strong enough, and they might get a very, very bad virus. As we keep comparing the virus with influenza, that is not as bad or is similar, but I have seen personally 2 of my colleagues who have almost died because of this virus. And they had the flu before, and it was never this bad. So this virus is really very, very bad for certain populations and some people, and you don't know who they are, and you may be the next person. So the cultural change that we need to emphasize, that we have to follow the mitigating recommendations and be very vigilant with that, is extremely important to follow. And that may find people who have masks and things like that, because that's what's happening in the community. And we may have another spread of the infections, second wave, as they call it, if we don't pay attention to these things. You know, the point that Larry made about, I'm sorry?
No, go ahead, please.
You know, and in terms of the vaccines, I agree with Larry. Herd immunity is the ultimate answer to this. When we have 60-70% of people with the virus will have nobody to infect, so it will go away. And the vaccines are not a promise. However, recent reports, you know, the vaccine from Boston and from England and every country in the world is working on a vaccine. And this is really an unprecedented, maybe HIV had something similar, but this is a run against time. And there's some improvement, some hope. I wouldn't be as pessimistic as this is not a possibility. I think it could happen. It has some challenges, and is not going. And the safety issues are going to be very important to consider, because if you choose an antibody against the wrong antigen, you may accelerate the immune response, and you can create a very sick patient, or may create a vaccine that doesn't do any good. So how you do the vaccine is extremely important. I have read that there's over 360 patents and right now with the FDA for treatments and vaccines for COVID-19. So something will happen hopefully in the near future. The testing will be used primarily to see if you are immunized, and hopefully our testing will be better by then. Right now, the testing is really bad, and although the name of this talk or this conference is about testing, the main point that I would like to get across here is that if we don't know the prevalence of the disease, specifically in each particular area, we are not, we don't know how to interpret the test. And right now we need to collect that data. Miami-Dade has done it. They published a little paper relating their experience. I will hope that we can get something like that for Palm Beach. I think that is doable. And then we have a better way to interpret a positive result or a negative result on the patient that we test.
So I've got one more question for the group, or we've got 5 minutes to go, and I want to be respectful of everybody's time this evening. And the last question is, doctors' offices are trying to reopen. Doctors are trying to get patients back in to care for the diseases that they've maybe put aside that are chronic and as important. And so they need to feel comfortable as they enter the doctor's office. We're all taking precautions. Should physicians get tested? Should the staff in a physician's office or a medical office be tested in order to make patients feel more comfortable as they come back? I'm going to Dr. Bush, and you've got 2 minutes.
So I don't think so. I think you do all the correct public health prevention things, hygiene, disinfecting, gloves, mask, etc. in the office. That's as good as it can get, because a negative test today doesn't mean a negative test tomorrow. I think that if you do those things, testing people working in the office or the physicians is no different than saying that your surgeon should have an HIV test before they operate on you.
And Dr. Arrascue, you've got 2 minutes also. What do you think about testing?
Sure. I think that the testing, because of the multiple problems that we have discussed at length, is a personal choice. You know, I did it myself. I wanted to know. I hope I could be part of the study for the prevalence of in Palm Beach. But the most important point to open your office is to follow all the recommendations from the CDC. As you know, the Palm Beach County Medical Society, we have a task force to how to reopen your offices, and we have a very excellent document that advises physicians' offices how to open in a safe way, in a way that we protect our patients and we protect ourselves, and we should follow that. And the issue of testing, I will say maybe if you are an oncologist who see a lot of immunosuppressed patients, if your patients know that you're negative, you may have a little bit more of a confidence on you, the patients, because, you know, the fact that you are negative could also mean that you've been doing everything right. certainly you can be positive tomorrow or next week, but up to now, you've been doing very well, and that will add to the confidence. Nothing is perfect here, and everything that we can do to improve the confidence of the public on us is important. If you saw the political problems last Sunday, the president of the Association of Skilled Nursing Facilities was interviewed, and he made a point that they would like to have point of testing in their facilities. So anybody who comes in gets tested for the virus. If they are negative, they can go inside and visit their loved ones. So this is something that is evolving, and testing, I believe, as becomes more available, more reliable, better way to interpret the results is going to be more something that you do more often, especially if we don't have a vaccine, and we still see that some selected populations can really die from this virus.
So thank you all. Thank you to the panelists. Thank you to the participants. I recognize that there are a tremendous number of unanswered questions and individual questions, and many of them have come through in our chat. And really, this format doesn't lend itself to answering all of them. What we've tried to do tonight is phrase a series of questions about testing in Palm Beach County and have experts answer those for you. And I hope the answers have helped you as you plan to move forward. Again, I want to thank the panelists who have served this county, many of them for decades, and will continue to do so. I want to remind everybody on this call that the Palm Beach County Medical Society is here for you. We have a task force, as Dr. Arrascue mentioned. We have a resource page on the website. We have staff that's knowledgeable and working for everybody on a daily basis. We have leadership, including Dr. Bush, our president, and several past presidents that are really working hard to be a source of information for everybody, physicians and the public. I want to compliment everybody on this call. Your Zoom etiquette is outstanding. So we did this with really good technology, and we appreciate you. So thanks for joining us. Keep an eye out for the next source of information from the Medical Society and leadership. Have a good evening, everybody.
Good night.
Thank you, Jim.